All diuretics act directly at their specific sites. Here we have a figure showing the different types of diuretics with their examples corresponding to their specific sites on the nephron. Diuretics such as carbonic anhydrase inhibitors, xanthines, and osmotic agents all directly act to the proximal convoluted tubule. These diuretics alter the increase and decrease of the renal blood flow. For the ascending loop of Henle, the loop diuretics decrease reabsorption of sodium cations and chloride anions, while the osmotic agents increase urinary excretion. Thiazides inhibit luminal sodium reabsorption in the early distal convoluted tubule. Lastly, the potassium ion-sparing diuretics are responsible for the increase of diuresis or urination in the late distal tubule and collecting duct. Manitol is the most commonly used osmotic diuretics. It increases renal medullary blood flow via a prostaglandin-mediated mechanism. It reduces medullary tonicity, resulting to the decrease of extraction of water, and lowers concentration of sodium chloride along with its passive reabsorption. It is useful for the treatment in renal failure, reducing the intracranial and intraocular pressure. With other diuretics, it also helps mobilize edema. It has to be administered intravenously due to poor oral absorption. Slow intravenous infusions take over 15 to 30 minutes and can be repeated every 6 to 8 hours. This is applicable to all species. Adverse effects aren't much. Toxicity is a rare case. The urine output and the fluid and electrocyte balance must always be monitored, especially for cases such as oliguric renal failure. It should not be used in generalized edema frequently, as each successive dose will cause it to pass through tissue barriers, drawing water in instead of drawing water out. It must also be used with caution for acute pulmonary edema, as this may cause expansion of the intravascular space, resulting to heart failure.
So carbonic anhydrase is the product of carbon and water, whereas if it is catalyzed, it breaks down and forms into bicarbonate and hydrogen ion. So this is the formula. So the carbonic acid forms in small amounts of carbon dioxide, which is dissolved in water, yet decomposes rapidly under ambient conditions of temperature and pressure. This class of drugs was discovered as a result of the observation of the sulfanilamide chemotherapeutic agents were capable of causing metabolic acidosis by inhibition of the carbonic anhydrase. Screening of sulfonamides resulted in identification of compounds whose predominant mechanism of action was carbonic anhydrase inhibition. These drugs have been used sparingly in veterinary medicine as diuretics and are more commonly used for ophthalmic purposes as topical formulations. Some of its examples include acetazolamide, metazolamide, and dichlorphenamide. The activating step in the process of bicarbonate absorption is the secretion of the hydrogen ion into the tubule lumen, which is largely responsible for the favorable electrical gradient done with the sodium diffuses into the cell. The hydrogen is derived from the dissociation of carbonic acid, whose supply is facilitated by the presence of the carbonic anhydrase. The carbonic anhydrase inhibitors interfere with the absorption of the bicarbonate from the proximal tubule by reducing the supply of the hydrogen ion to the membrane pump and by reducing the rate of the absorption of carbonic acid from the lumen. Therefore, the filtered bicarbonate is thus trapped in the urine together with an electrically equal amount of sodium and an osmotically equivalent amount of water. So these drugs can cause an increase in an excretion of bicarbonate with accompanying sodium, potassium, and water excretion, resulting in an increased flow of alkaline urine with mild metabolic acidosis. So mechanism of actions, it is reversibly inhibit the carbonic anhydrase enzyme, predominantly in the proximal convoluted tubules, causing a reduction in hydrogen ions available for the sodium and hydrogen exchange pump, or the sodium-hydrogen antiporter. The carbon dioxide reabsorption from the glomerular filtrate is suppressed and the sodium bicarbonate excretion is increased, resulting in the alkaline urine. So for its therapeutic uses, reduces the rate of aqueous humor formation and the treatment of glaucoma, occasionally used as adjuncts in the treatment of metabolic alkalosis. So for its pharmacokinetics, acetazolamide and dichlorphenamide are absorbed orally, which is distributed to the tissues with high carbonic acid concentrations, particularly on the renal cortex, eye, and erythrocytes, and is excreted by the kidney by active secretion and passive reabsorption. Onset of diuretic action is 30 minutes with a duration of 6 to 12 hours in small animals. For administration, in glaucoma, acetazolamide, metazolamide, ethazolamide, or dichlorphenamide are given orally 2 to 3 times daily. In acute cases, a single intravenous doses of acetazolamide is given, followed by an oral dose regimen. So for its adverse effects, toxicity is rare, but gastrointestinal disturbances, especially vomiting, may occur with oral administration. Carbonic anhydrase inhibitors are contraindicated in the presence of the liver disease because they may precipitate hepatic coma by diverting ammonia produced in the kidney from the urine to the systemic circulation as a result of urine alkalinization. So in general, carbonic anhydrase inhibitors blocks carbonic anhydrase, thus it blocks the sodium bicarbonate reabsorption and decreases hydrogen ion in the tubule lumen, whereas the sodium hydrogen exchanger is disabled, thus it causes diuresis.
Aldosterone Antagonist is a diuretic drug which antagonizes the action of aldosterone at mineralocorticoid receptors. Examples of aldosterone antagonists are espironolactone, eplerenone, and candrenone. In collecting tubule, promotes sodium ions reabsorption and potassium ion excretions. It activates sodium ion channel, causing the rapid reabsorption of water into the tubular cells. Antagonist competes with aldosterone by combining with the sodium ion channel receptors. The channel does not often result to failure or reabsorption of sodium ions from the collecting ducts, leading to diuresis with a significant natriuresis. In acidifying salts, some inorganic quotients produce weak acidotic diuresis such as ammonium chloride, ammonium nitrate, and calcium chloride. The mechanism of acidification is represented by the following equation. To explain, ammonium chloride, after absorption, is metabolized to form hydrogen ions, chloride ions, and urea. The accumulated chloride ions displaces bicarbonate from sodium bicarbonate and potassium bicarbonate, forming sodium chloride, potassium chloride, and bicarbonate. The hydrogen ions combine with bicarbonate ions, yielding carbonic acid, which splits to carbon dioxide and water under the influence of carbonic anhydrase. Neutralization of bicarbonate and formation of carbonic acid or carbon dioxide result in metabolic acidosis. The higher concentration of sodium chloride, potassium chloride, and urea exerts increased osmotic tension in renal tubular fluid causing osmotic diuresis. Therefore, urea, sodium chloride, and potassium chloride exerts osmotic action in tubules and are excreted through urine along with waters.
Mechanism of action of different classes of diuretics.
So drugs like carbonic anhydrase inhibitors act on the proximal convoluted tubule. These are drugs like acetazolamide. which is a non-competitive inhibitor of carbonic anhydrase. Carbonic anhydrase catalyzes the reaction of CO2 plus H2O to give H2CO3 to give hydrogen ions and bicarb. In the proximal convoluted tubule, sodium is exchanged for hydrogen ions. As carbonic anhydrase inhibitors affect this pathway, fewer hydrogen ions are available for exchange of sodium ions. Throughout these examples, you will see that when sodium is left within the tube of the nephron, it carries with it water, and therefore water is excreted in the urine. Osmotic diuretics act in the loop of Henle. Drugs like Manitol, which is an osmotic diuretic, is freely filtered by the glomerulus and is not reabsorbed. Water follows mannitol as the osmolality of the filtrate is increased. So mannitol is stuck within the nephron tube and cannot escape, but it can drag water in with it, and that's how it has its diuretic effect. So loop diuretics act mainly on the thick ascending limb of the loop of Henle, and less so early on in the distal convoluted tubule. They inhibit the reabsorption of sodium and chloride. This impairs the countercurrent multiplier system within the nephron, and the medulla becomes less hypertonic, so less water is absorbed. Once again, whenever sodium is left within the tube, it will carry water with it and excrete it out. Thiazide diuretics act early within the distal convoluted tubule and act very similarly to loop diuretics. You can see they also inhibit the reabsorption of sodium and chloride ions. With the increased sodium and chloride ions in the tube, more water is excreted. Potassium-sparing diuretics act at the distal convoluted tubule, and these block sodium and potassium exchange, so less potassium is lost in the urine and more sodium remains in the tube. Once again, magically, once sodium is left in the tube, more water is excreted. Aldosterone antagonists are our last class of diuretics. These act at the distal convoluted tubule and the collecting ducts. They're competitive antagonists of aldosterone, which is important because aldosterone stimulates the reabsorption of sodium in exchange for potassium. So, if these receptors are blocked, you get no sodium reabsorption, therefore sodium stays in the tube, therefore you lose water. Let's recap. We've got carbonic anhydrase inhibitors, osmotic diuretics, loop diuretics, thiazides, potassium-sparing diuretics, and aldosterone antagonists. Examples of aldosterone antagonists include spironolactone. Examples of potassium-sparing diuretics include amiloride. Examples of thiazide diuretics are benterflumethiazide. Osmotic diuretics, as we know, mannitol is really the only one we use, and carbonic anhydrase inhibitors are weak diuretics, and acetazolamide is an example of this. Probably the most widely used diuretic in critical care anesthetics is furosemide, the loop diuretic.